Okay, you guys can see my screen, right? So this is not much of a you can see my screen? Someone?
Yes.
Okay. This isn't too much of a mystery case, but so we have this big, there's a big mass affiliated with the pancreatic tail and invading the spleen. We can see that it has calcifications within it. And then we have these extensive liver lesions. One point about the liver lesions is that you can see them much better on the arterial phase here than on the venous phase. So this was a kind of classic large pancreatic neuroendocrine tumor with extensive hepatic metastases, also a lot of nodal metastases here. And then I have a companion case. This patient had a liver lesion, a large liver lesion. It kind of enhanced ISO to the liver and then kind of washed out. Anytime you see that, and we don't have definite liver disease here, you always want to think about neuroendocrine tumors and check the mesentery. And in this case, we can see the nodal metastasis from their neuroendocrine tumor in the mesentery down here. So the first one was pancreatic neuroendocrine with liver mets, and then this one is a GI, probably terminal ileal neuroendocrine. This is the nodal met. We often don't see the primary tumor within the bowel because they're often very tiny and multifocal, but we'll see the nodal metastasis and then the liver metastasis. So in this case, this patient, they thought they basically only had this one site, and they found one other site intraoperatively. So they did, it's oligometastatic disease. So they did hepatic resection of this lesion. For neuroendocrine tumor, if you have diffuse disease, they're not going to do resection, but if you only have one or two metastases, they might do it. The rule is also that however many metastases you see, there's probably twice as many, because on autopsy studies, you'll see twice as many mets in the liver as what we see on imaging. So the patient got resection and came for follow-up. This was their follow-up exam. We did a biphasic exam. You can see that that big met has been resected. There are a couple of other like stable lesions, like a cyst here. And they had another resection over here. We're not seeing that much in the arterial phase, but one caveat I would say is that this is too early. This is a very early arterial phase, and so we're not getting good enhancement of the liver. We're not in the hepatic arterial phase yet. But on the venous phase, we started seeing lesions, very subtle lesions like this one here. And if you narrow your windows, you can see them a little better. So there's a lesion, another one next to the resection site. So they thought, okay, the patient is developing a couple more lesions. Should we ablate them? Should we do something about them? It looks like there's only a couple of lesions. So they got an MRI. This is the pre-contrast, which often I usually like pre-contrast to look for the borders of lesions and for liver lesions. And again, we can see that there's probably a subtle lesion here. There's a lesion here. On the arterial phase, we started seeing a few more lesions. So these are tricky because on neuroendocrine, sometimes you see them better on arterial, sometimes you see them better on portal venous. Maybe another lesion here. So I wasn't sure which sequence to use. And then the point of my case is then I went to the diffusion, and this is what the diffusion looked like. So even though on the pre-contrast, we could only see 3 or 4 lesions, there were over 50 lesions throughout this liver. So diffusion is really, really helpful. So arterial phase is very helpful, especially for ones that are more arterial enhancing, and diffusion is very helpful. So just a couple of teaching points. Diffusion has a much higher sensitivity for picking up neuroendocrine metastases, more than T2 and post-contrast. These are the therapeutic options for neuroendocrine tumors. So some of them are for syndrome control. So octreotide is what was used in the 80s. They started using long-acting octreotide or lanreotide in the 90s. And then more recently, we've gotten some anti-proliferative therapy. So this is not just symptom control, but actually helping you. So everolimus was starting to be used for pancreatic neuroendocrine tumors. And the really exciting thing is that recently they've started doing peptide receptor therapy. So basically radiation that is attached to a radionuclide for gastroenteropancreatic neuroendocrine tumors. So just a couple of notes about PRRT, which is peptide receptor radionuclide therapy. These are for grade 1 and often for grade 2 neuroendocrine tumors with metastatic disease. If there's no progression or slow progression, they're often on lanreotide, which is a somatostatin analog that can control symptoms. But if they show progression and these lesions are active on an Uptria scan, or even more recently we use dotatate scans, then they could be a candidate for PRRT. Being active on dotatate scans means that the metastases have somatostatin receptors, so they will be susceptible to these somatostatin-like proteins that are attached to a radionuclide. So this is a radioactive lutetium. This PRRT is called Lutathera, and we're using this more and more for patients who have liver disease with progression. And this is just one example from the literature where you can see that there was extensive activity in the liver prior to Lutathera therapy, and after 4 cycles, you can see that there's actually a significant decrease in metastatic disease in the liver. And it can treat other mets in other places too, like in the bones and other organs. So, any questions?